Hello, everybody. My name is Dr. Vince Gutierrez. I'm a physical therapist. I'm also certified in MDT. Today, I'm going to discuss centralization and how it correlates with discography. This is based off of the study from Ron Donaldson and Robert Metcalf. So, just some background information. Centralization is the movement of symptoms from a distal location to a more central location, first described by Robin McKenzie in the late 1950s. And the movement that causes this centralization phenomenon is called the directional preference. The directional preference was first described by Ron Donaldson in about 1991 ish. So, what centralization is as a physical therapist or a chiropractor or a physician that understands these principles, they're looking to move the patient into specified directions to see if we can move the symptoms maybe from their leg to their back, or from their side of the back to the center of the back, or from the center of the back to completely gone. Okay, so it's taking the symptoms from some place that's far away from the back, bringing the symptoms to the back while turning them off in that place that was far away from the back. Peripheralization, on the other hand, that's the exact opposite. This is movement of symptoms from a central location to a more distal location. And movements that cause this phenomenon are called directional vulnerabilities. And again, peripheralization, there's a ton of research on centralization already. I mean, you can look at Wernicke's research to show that you have good outcomes if you can see this by the seventh visit. It may take up to 7 visits to note centralization. If it's not noted by the 7th visit, you tend to have poorer outcomes. Centralization is a predictor of whether or not a patient is going to improve, and there's one research study out that notes that centralization has an effect in terms of total outcome. Peripheralization, on the other hand, can also be a predictor. There's a research study by Skite in 2005. Sorry, I'm pretty sure I'm going off the top of my head here. Skite in 2005 that notes patients are, I believe it was 6 times more likely to have an invasive procedure if centralization only could be found during the evaluation, meaning that there was no, if peripheralization only could be found during the evaluation, meaning that there was no centralization. And then, this study we're going to discuss how centralization and peripheralization actually play out in terms of correlating with discogenic pain. So the dynamic disc model, over the years there's some conflicting evidence. It was initially taught that when a patient flexes forward, the nuclear material or the fluid-like stuff that's in the middle of the disc will move backwards, and when a patient bends backwards or goes into extension, the fluid stuff that's in the disc, the nuclear material, will go forward. This was first proposed by Robin McKenzie in 1981 in the textbook, meaning that the direction of movement that centralizes is the direction of migration of the nucleus pulposus, meaning that you can have a mechanical pain of the annulus or the nerve root. We know pain is a little bit more complex than this now, but maybe it's not. We'll go into that a little bit more in the study. And an offset load can reduce symptoms by displacing nuclear content. That's the toothpaste type content that's in the middle of the disc, that nuclear material. When you move, it moves. And theoretically, when you move in one direction, it was thought to move in the opposite direction. So if you move backwards, it was thought to move forward. But there are some cases where that doesn't hold true. And when you do see this centralization phenomenon, the thought was that the hydrostatic mechanism must be functional, meaning if you picture a water balloon, when you push on the back of the water balloon, the fluid moves to the opposite side. You push on the tube of toothpaste on the back, the toothpaste moves towards the front. But if there's a hole in the water balloon or there's a hole in the toothpaste and you push on the toothpaste container, you might actually push it out of the hole. And that would mean that the container that the toothpaste is sitting in is no longer intact. And when they're talking about the disc, what they're looking at is the annulus, that area of the outer rings of the disc. And they want to know if that is intact or not. And if you see centralization, the thought was that was intact because you're able to exert your force on the disc. The theory is if all you can do is peripheralize, the hydrostatic mechanism may no longer be intact, which means that there may be a hole in the water balloon, or a hole in the tube of toothpaste, or a hole in the disc that is no longer allowing you to exert the force that you thought you were going to have on the disc. Diagnostic disc injection, I'm not even going to come close to going into this because this is way over my head. It's not my specialty. So just know that in this study they did provocation discography, and it was to provide direct info about the nuclear envelope, the annular rings or the tube of toothpaste that encompasses that nuclear material. That's about as far as I'm going to go into this because, again, this is not my specialty. So the study overview. It's a prospective study. They were blinded, so the therapists weren't quite sure of the results of the discography. Plus, the therapist saw the patients first, so they didn't know the results of the discography anyways. But when we look at this, the centralization phenomenon, so the hypothesis was that if the patient centralizes, they were going to call that a discogenic pain, and the hypothesis was that the annulus was intact, the tube of toothpaste, the container that holds the nuclear material. If the patient peripheralized only, they were also going to call this a discogenic pain, but they would say that the annulus is no longer intact. If the patient did not centralize or peripheralize, they were going to hypothesize that this was non-discogenic pain. And they were using the discography in order to assist with their correlations. So the methods. You had 63 patients with low back pain, could either have or not have leg symptoms. The average age of the patients were 39. The average duration of symptoms was 15 months. Okay, so there's this, in healthcare, you'll hear frequently, especially if this is a patient listening to this, you'll hear frequently, you'll get better over the course of 6 weeks. You'll get better over the course of 6 weeks because the natural history of back pain has been taught that it's going to get better over the course of 6 weeks. But obviously it doesn't happen that way. The stats, I'm a little fuzzy on the stats, but I think a quarter of all chronic pain is back pain related. And so obviously not everybody gets better over the course of 6 weeks. And as you see with this study, the average duration of symptoms was 15 months, meaning that some people had this longer than 15 months, some people shorter than 15 months, but still on average 15 months. Most of the patients in this study had symptoms below the knee, meaning you could have symptoms into the foot, like numbness or tingling or pain. And 70% were not working due to back pain. Those who had a history of a lumbar surgery were not allowed to take part in the study. The MDT eval and classification was performed prior to the diagnostic injection. All evaluating PTs were diplomats in their training, which means that they had gone through the credentialing process, which is taking 4 courses and then taking an exam. But with a diplomat, you have to take 4 courses, the exam, and then sit in a type of residency program and take an additional exam. And you have a long period of time of didactic work also in order to become a diplomat in the system. So needless to say, all of the therapists that were evaluating patients were very highly trained to use this system. The PTs were blinded to the patient's past medical history and any previous imaging. 3 effects were recorded from the evaluation. 1, did the symptoms centralize or did the pain completely abolish? 2, did it peripheralize in one or more directions without centralization? Or 3, was there no change in pain intensity or location? The diagnostic disc injection was done immediately after the MDT evaluation. The investigator was blinded to the MDT evaluation classification. The 2 lowest discs were studied initially. When you look at the previous research, and again, I don't have any of this stuff in front of me, but when you look at the previous research, I believe it was 95% of symptoms correlate with L4, L5, L5S1, and only 5% of symptoms correlate with L1 through L4. So if that's the case, they're going to look at the most lower 2 segments because those tend to be the 2 segments that are symptomatic. And the 2 lowest discs were studied initially. A minimum of 2 discs and up to 4 discs were studied, and this is based off of where the pain location was at. And they had to have at least 1 controlled disc, meaning that they had to have 1 disc that was believed to be asymptomatic in order for them to assess whether or not there was a symptomatic disc. The pain response was assessed during the injection, meaning did the patient say, nope, that didn't hurt? Yeah, that's kind of the pain that I have when they injected. When they inject, did it reproduce their exact symptom that they would normally complain about? Or was it a pain that was not consistent with their normal pain that they were experiencing? They also underwent a CT scan, and a positive discogram was correlated to be the exact pain reproduction and an abnormal image, and this is assuming that they had no pain at a control level. So when they injected a disc that wasn't thought to be impaired, if the patient had no pain, then when they injected the disc that was thought to be impaired and they complained of their exact pain, they correlated that with a discogenic pain. The results of the study, after the MDT assessment, roughly 50% of patients could centralize with a directional preference. This is a little lower than what you see in the research. In some of the research, the research has it going from roughly 49 to like 64% if you just play out some of these prevalence research. But that's still half of your patients could centralize with one movement. And again, centralization typically leads to a good outcome. 25% of your patients peripheralize only, and 25% of the patients, again, these are patients that have had symptoms for 15 months on average, 25% of the patients have no change in location of symptoms. This is important because many therapists believe that centralization or directional preference is only seen in acute or subacute based patients, meaning patients who have had symptoms for less than 3 months. But we know from a previous Donaldson study that I think up to 40% of patients can have a directional preference even if they have chronic symptoms. And this study is also showing you that chronic symptoms can still present with a directional preference in roughly 50% of the cases. Discogram results. 58% of them had a positive discogram, of which 81% did not leak dye, and 42% had a negative discogram. Correlation. Of the 50% that centralize, 74% had a positive discogram. 91% of those with a positive discogram had an intact annulus, which means that you had a 75% likelihood that this is discogenic in nature. And those that this is discogenic in nature, when you see centralization, you have a very high likelihood that the disc is still intact. Of the 25% that peripheralized only, roughly 2/3 had a positive discogram. But of those 2/3, it was a coin toss as to whether or not the annulus was still intact, meaning that you had a higher percentage that this disc is no longer functioning with its proper hydrostatic mechanism. Of the 25% that had no change in location of symptoms, a very low percentage had a positive discogram, and 100% of them had an intact annulus, meaning that if the symptoms don't change in location, you may not be looking at a discogenic symptom. So what does this mean? The MDT assessment correlates with invasive techniques for determining discogenic versus non-discogenic pain. Roughly 75% of the time it correlates with a discogenic pain. And it also correlates with the assessment of an intact or a non-intact annulus. As you saw before, those who centralize have a very high % chance of having an intact annulus. Those that don't centralize or peripheralize have a very low chance of being discogenic pain. Most that centralize had a positive discogram with near 100% having an intact annulus. Like I said, it was 91%. Most that peripheralize had a positive discogram, meaning that if the symptoms change in location, there's a high correlation that symptom is coming from the disc, and it's about a 50% chance whether or not the disc is actually intact. Those that don't have pain changing location have a low rate of a positive discogram. Here's the reference. But the reason why this study is important is because there's still physical therapists that have they're kind of swinging with trends, right? And when I first got into this profession, 2007, back pain was attributed with being discogenic in nature. And there are still some studies that say that, most back pain is discogenic. The trend seems to be swinging right now to we're not going to define where the back pain is coming from, because we can't define where the back pain is coming from. And pain is so personalized that it's hard to say where the pain is coming from. But this is a good research study to demonstrate that we can't just throw the baby out with the bathwater. We can't just say that because pain is this puzzle and it's personalized and it's individualized to that person, we can't just throw away the anatomy that could be happening in that patient, especially if we're seeing centralization and peripheralization. So just remember this in your clinics, that you should still be assessing patients with motions, right? Determining if it has any change on their symptoms, even if the patient has had symptoms for longer than 3 months, because many people will just associate this with being chronic pain, and they will go and do pain neuroscience-based treatment approaches such as graded exposure, nerve glides, and such, when in reality, you're still going to have a high percentage of your patients have changing pain locations, which can assist you in your classification and treatment of these patient symptoms. If you have any questions, post them in the comments section. I'll try to get back. Have a good day.